end that and try and see there are some more tips that we could extract from Prof. David. And feel free to sort of put up your hand at any time if you do have questions. I'm just going to kick off. That doesn't mean that it's just me who's going to, but feel free, please, to join in and start off at any time. I'm going to start with a very, very sort of esoteric question. Prof. David, do you agree with the term mitral valve to the mitral valve? Why? I mean, I've seen so many of Bishop's mitre. I've got it on a slide which shows at least 20 styles of Bishop's mitre, and none of them really matches the mitre.
I don't know who called it. Vesuvius, I guess, called it mitral.
Yes,
because
indeed.
of the analogy to mitre, the Bishop's mitre. But it doesn't look like a mitre at all. But
not at all.
No, particularly function, but it is what it is. It's difficult to change. What I do disagree, however, and there's an editorial coming up in one of the surgical journals written by me, only one page. I did some research on nomenclature for leaflets and cusps.
Yes.
We surgeons and cardiologists use the terms interchangeably.
Correct.
And apparently, leaflet refers only to atrioventricular valves, originally, and cusps to the pulmonary and aortic, the semilunar valves. But the name of them, I never...
Well, it's just... No, of course, we are stuck with it now, and it's very, very difficult to obviously change something which is so ingrained in history. But you always wonder that, you know, it has been misnamed, and now we are stuck with it, and that's what we are dealing with it. Just carrying on, I know there are going to be lots of points. I've really got quite a few points to discuss, but I've always also really been very unsure of sizing the mitral valve for replacements and sizing the mitral valve for annulus. And I find it very, I know the concept that we use the anterior leaflet and then stretch the anterior leaflet, and then you get the sort of part of posterior leaflet. I can see you smiling. And then you size the annulus, annuloplasty ring on the basis of that. And if you wanted to replace the valve, you take a sort of circular ring on the ring which does not exist. And then replace it with a circular, rigid, mechanical or tissue or bioprosthetic valve. How do you feel about that? You know, because I'm sure you are a lot more experienced. You can probably put any size ring in any valve in terms of repair. You know, you get just a brief idea, but 30, 32, 34, does it matter so much? But if it doesn't, then there is something else.
Some 15, 20 years ago, when I had accumulated a size of experience and was comfortable repairing valve, we used to have teleconferences frequently to teach other surgeons. Sure. And I started as an North American as far back as 1994. You know, lectured here, 300 people, live operations, and it's fascinating to see the argument. And Professor Carpentier was my first moderator, and vice versa, and I moderated Professor Carpentier many times. They take a sizer, they put in the valve, they say 32, challenge them. I'll bet you a 34. They pick a 34, well, maybe you're right. Somebody else, no, I'll put a 30. So suddenly it can be a 30, 32, or 34. Which is the right size? We don't know. So I stopped sizing 20 years ago. I don't size anymore.
That is a very, very important thing.
Honestly.
Please.
If the ventricle is normal, I don't size anymore. I put all my sutures there, and I don't know if you pay attention to the video, I didn't size at all. And this video about over 10-year-old. Yes. Take a band, a straight band. I used to have, Edwards used to make in Crossgrove 44. There's no 44 in the market. And I used to use whatever length I need, cut the rest. Then some 7, 8 years ago, Medtronic came up with the Simplicity. 10 centimeter long, I use anywhere between 5.5 and 8, depending on the pathology, depending on the size of the patient, depending mostly on the size of the leaflets. But I plicated the annulus selectively. In other words, the bites are all equal, but I plicate where the false commissures are and the true commissures are. Don't plicate the rest.
And maybe plicate a little where there is pathology?
Oh, absolutely, yes.
Yeah, yeah. So
decrease the tension there.
I think these are very, very important points. sizing, I'm almost at the point of writing sizing the unsizing of the mitral valve. I hold a patent. I hold a patent for sizeless annuloplasty
You should and send to Hank Edmonds, because there's a paper of mine coming up this year in Annals where I start with 3 quotes. The first quote is from Hartzell Schaff from Mayo Clinic. I use a 63 millimeter in every patient. And then Antonio Calafiore, when he was in Sicily, he put a paper. I use a 50 millimeter band in every patient. And then Stephen Bolin is not the ring, is the ringer idiot. Typical Stephen Bolin. And then I go to describe, I don't size at all, do whatever the patient needs, and the rationale for not sizing, with results, of course.
Yes, absolutely. The idea is to achieve a percentage reduction, which is, I mean, it's difficult to totally differentiate, but it's not related specifically to sizing. It's just a percentage reduction. That sort of, I was thrown into Africa to operate on mitral valves, some of them rheumatic, and then you realize, God, you get a piece of cloth, really, to put something like an annuloplasty ring, and you get over it. But that brings to my second, one of my PhD students is starting a project as we speak on what is a normal mitral valve in relation to body surface area or heart size. Is there any correlation to that?
The normal one we do, but we don't operate in normal.
No.
So,
but we want to get it back to normal after repair. Exactly.
Well, apparently in diastole is 5 centimeters square per meter square, the orifice. And that's not functional orifice, anatomic orifice. Functional, very seldom, more than 3 or 4 centimeters in anybody. Our mitral valve opens to 2 up to 4 when they are in maximum exercise. But so
30 cc syringe.
Yes.
That was the size that once you repair it, that'd be done. You had to be able to slip
30 cc syringe. Well, yes, a lot of people have been to put 2 fingers and see if your finger moves in.
The problem is there are patients that have very small anterior leaflet, like 22, 20 millimeter tall only, 18, 20 millimeter wide. Those patients, to this date, they intimidate me. I do a ring because I show my own data. If I don't ring them, they come back with recurrent MR 10 years later. So I ring them. But in the end, the operation is 1.8, 2 centimeters square opening. That's mild mitral stenosis.
And before we had this thing, we used to use a piece of shoelace. Standard shoelace. The simplicity ring costs about 100 times as much.
And whether this stenosis is anatomical but may become more symptomatic in function.
Yeah, because the panels you're going to cover, the ring is going to make stiff leaflet at the bending area, so it's going to get worse only.
Yes,
just to follow up on this discussion, because the fibrous skeleton and the relation between the anterior leaflet and the aortic valve, Duran had suggested that if you measure the annulus of the anterior valve on an echo,
1/3, yes,
and you divide by 0.8, that's the size of the ring you need to put in the mitral position for that patient. Do you believe in that?
Well, that's the normal one. So he's using a normal anatomic finding to.
So you don't actually need to go in and
size.
Yes, you almost before you start the operation, you can. I'm going to put a 32 ring, whatever.
Yeah, well, I think it's correct. Yes.
Quite a few formulas like that.
The only thing is the pathology is the spectrum of pathology is so broad that I think what Hartzell is doing, Hartzell Schaff is doing 63 for everybody. Can you imagine? I mean, those 2.5 meter square Americans, the all American boys, to have a same band as a midget, or you can't. I think that's a bit of an exaggeration.
And I think it adds on to the fact, I was the MD to PhD supervisor for Mazi Kanani, who did the work with Prof Anderson, and he was the one who sort of, the absence of the annulus on the posterior. And maybe that is what is also contributing to this opening up annular dilatation.
I think it is. I think you're right, yes. As a matter of fact, a pathologist from Hopkins is dead now, called Hodgkins. He published this in 1986, and Professor Anderson criticized his paper in the New England Journal of Medicine because he described the displacement in the posterior leaflet. And Professor Anderson said, there is no mitral annulus posterior in most human beings. Both are right. Hodgkins describe anatomic finding, and Anderson is saying that perhaps people get big annulus because there's no annulus.
Yeah, yeah, yeah. And there is a lot of sort of feeling between flexible and rigid ring. I saw a lot of, obviously, in your degenerative, a majority are flexible. And ischemic MR, I presume, are rigid.
Rigid.
And
cardiomyopathy, rigid. In people with impaired systolic function, I have no proof of that. My patients that I operate on do better if I put a rigid ring in impaired systolic function, 20% ejection fraction. People with a hyperdynamic heart, I want to put the biggest possible ring the mitral valve can accommodate to make the mitral valve competent. And don't want anything across the intervallar fibrous body. It should be leave alone, not to affect function. Messana from Ottawa, I don't know how many of you showed, he repaired mitral valve only with Carpentier's technique. So he resected leaflets. I use the Gore-Tex the way I do. So he has less leaflet than I have. And that's the shortcoming in the study. But they took a look at what happened to the functional orifice in PA pressure on patients at Carpentier technique with Carpentier ring during exercise. PA pressure goes up to 60 or 70 in 2/3 of the patients, indicating that it's functionally stenotic.
Yes, I think that is the indirect marker of that, absolutely.
I don't have this. My patient can exercise much. Actually, I have 2 or 3 dozen professional athletes. They don't fall behind their peers.
And these are all incomplete bands using the sort of fibrotic area between the left and right fibrous. There was some of the Italians who suggested that, the annulus continues to dilate. But I think presumably they were then not fixing it to the annulus, to the fibrotic annulus.
Fixing posteriorly, likely.
Yes. Yeah. So again, I think it's important that you reach the dimple, the right and left fibrous, or whatever.
The lot of fibrous trigon, any medical student, let them put a stitch in the heart, they know where it is. It's like stitching in the wood. The medial one is more difficult. The medial is difficult to see from the left atrium. From the aortic valve, you know where it is. When you take the non-coronary cusp to replace an aortic valve, you can see how far down it is. That's the opportunity to teach fellows and residents where it is.
From the aortic.
Is into the anterior leaflet mitral valve, at least 5-6 millimeters away from the commissure. So I suspect if you put a band from the commissure downwards, that part can dilate yet.
And still, also because that part is not straight enough, then it sort of...
That's correct.
Yeah, so then it causes a disruption of the medial commissure as well.
So it's not a perfect C. It's more like a G almost. It goes into the anterior leaflet immediately. And on a lot of fibrous trigon is straight down.
And that's why, again, it's quite important to understand that it's not just the C that you're trying to carve up. You have to make sure that you get the effort.
Trigon,
I can carry on, but are there any questions here? Do we have any? Yes, of course. We've got one here. Mike, please. Thank you. Oh. Yes, okay.
In your video, you sutured the papillary muscles to the annulus when you did the mitral valve replacement. Do you normally stitch one papillary muscle to the medial part of the annulus and one to the lateral for your mitral valve replacements?
Yes, I do. In rheumatics, particularly mitral stenosis, when rupture of the ventricle is the highest incidence in elderly patients with mitral stenosis. So we take the anterior is a single trunk usually. So you take a 4 Gore-Tex, pass 2 or 3 loops, and bring them a centimeter apart, like a 9 o'clock and a 7 o'clock. The medial is different. The medial has multiple heads. So you have to weave the Gore-Tex more times along the multiple heads, almost like to make a single head, and do the same way, 3 o'clock and 5 o'clock. How tight I make them? I make them taut. One of the muscles suspended and the Gore-Tex to be taut, but not excessively tight, because it can interfere with our mechanical valve or the pursuing valve if you put too far up. And it might rupture the muscle as well. The only purpose of that technique is not for ventricular function. Back in the 80s, we randomized Gore-Tex and no Gore-Tex. No difference in ventricular function. However, even in trial, we showed there was a 3% rupture of the ventricle with no Gore-Tex, 0 with Gore-Tex. Resuspension of the muscle prevents ventricular rupture. So much that this became a medical legal issue in the United States. You replace a mitral valve, the patient dies suddenly the next day. Autopsy show rupture of the ventricle. And you do not resuspend the Gore-Tex, the patient family got a case.
And that's partly because obviously in rheumatics you have to excise extensively, otherwise you end up for an adequate sizing, and so you free up everything. And so then you need to make sure. Prof. David, also in sort of, I think it was 67 or 68, when Estes produced the criteria for the different types of papillary muscle having different stalks. And then you remember that, and that created a lot of furore at that time.
That's right.
And then people got over it and then realized, okay, it's not really that so much, but it still has some role.
Value, absolutely.
Yeah.
The best study comes from India on papillary muscle. Is a pathologist called Victor. I don't know his
Victor,
first name.
yes, Solomon Victor.
Solomon.
Yes,
He
yes,
has the
yes.
best study. 1,000 specimens.
Yes.
And he divided up all the different anatomy. Very, very few identical. It's amazing how heterogeneous our hearts are.
And not just the attachment to
No,
the
no,
ventricle,
the whole- the
it's the
mitral valve
heads,
too.
yes,
Yeah,
absolutely. So it's really quite important that, again, the papillary muscle is not just, how you identify the head and how, and of course, although the other point when you said that I published in JTCVS December the technique. I use Pledget. I'm so sorry to say that. So,
No,
but the
apologies.
Pledget is on the anterior side of the papillary muscle. If the Gore-Tex is going to the posterior side,
Yes.
and then we tend to pull it down. So then again to follow the sort of same principle. But going back a little, the Bologna School of Anatomy also produced a paper where they were looking at the mathematical flow where the two papillary muscles in severe systole came back together in a straight line, and the chordae formed a straight line, again by the lateral and medial halves. And therefore, there they were able to determine that the maximum pressure point was on the center of the leaflet.
Oh, it is. It's the longest portion as well.
Exactly.
It's
And
low
also
tension.
that the anterior leaflet was able, because of the umbrella, to hold the pressure more than the smaller umbrella on the posterior, and therefore the posterior P2 was the
Yeah,
commonest
but
pathology.
ironically, if you believe that this is all mechanical problem, the anterior leaflet average anterior leaflet is 28 millimeter. A normal posterior is only a centimeter. So the anterior leaflet is 3 times taller than the posterior. If it's much taller, I would expect much more tension
Yes.
to be there. And yet we don't see rupture
Yeah.
to the anterior leaflet, more the posterior. So my explanation is the anatomy again, is because the way the heart torsion is, the posterior leaflet being so short is subject to much more stresses of the movement of the heart. The anterior is much longer to absorb the mechanical thing. I don't know if you follow me. If you take
Is the
from the tip of the
rotational
muscle,
ejection, yes. Yeah.
the lateral wall doesn't.
And maybe the same explanation applies to protection of P1A1 by the LVOT and providing less flow with the wall there, and maybe less incidence of
in
disease.
animals, if you in the lab you're looking at torsion, if you sever the anterior papillary muscle, no torsion anymore, becomes a pump that go back and forth. If you sever the posterior, keep the anterior, continue torsion.
All right.
So the torsion of the ventricle is caused largely by the anterior papillary muscle. So maybe it helps the mitral valve to have the whole thing.
I presume so, because again, it's, as you said,
The
most of the
lateral
disease you will
half
find
before.
9 out of 10 in the medial, and you have the LVOT, you have the lateral, you have the torsion. So again, I think it's quite important. And you also said that in the posterior leaflet, if you have a very large posterior leaflet, and that it causes SAM, but now we are using a lot of Gore-Tex, and sometimes my Gore-Tex are so short that the posterior leaflet is almost touching the papillary muscle.
But you have to. If you don't resect any,
Yes.
you're going to have to. Otherwise,
You think that's okay?
Of
It's
course,
a viable
yeah.
thing? Because that's what I do. I don't resect, but I mean,
And
sometimes you
I
have
didn't
to.
say that, but that's one of the problems in mitral valve repair. The moment you put a ring posteriorly,
Yeah.
doesn't matter what you've done to the mitral valve, put a ring posteriorly, the posterior leaf doesn't move anymore. Becomes like the frame of a door. In other words,
Allows the
it really is
anterior-
for this year only. Just lies there in a semi-open and closed position.
Yep.
So it's unlike that contributes to the orifice at all. So you transform a bileaflet valve to monoleaflet.
Yes, I agree. And that's been, again, part of my that we've always tried to convert a bileaflet into a unique
If you repair, don't put a band, both move normally.
And
so,
that may be better for LV remodeling post...
Likely so, but the worse for recurrent MR.
Probably.
The lack of ring.
Devil between the devil. Anything else that you have? Yes, sorry, yes, you had a point. Sorry, Alex, just we'll go to you next.
Is there any limit for, or guidelines regarding anterior mitral leaflet resection, if required?
Resection, for endocarditis we do, but for large volume alone, no. We try to save them. Large because it was just said, mitral valve repair transforms a mitral valve to a single leaflet valve, functional single leaflet. The other one is only to anchor the anterior leaflet. Very seldom. I thought when I stopped resecting, I started telling everyone, I'm using Gore-Tex because I want both leaflets to move. It doesn't. Only the anterior leaflet moves. So why to resect and lose orifice?
And it's a very severe form of disease where you get a very large billowing anterior. Generally, most of it is posterior, and so there are a lot of things to do on the posterior, but not having the need to do so much on the anterior. So excision of anterior is very uncommon. Alex, you had a point?
Yeah. It was just for the less experienced mitral surgeons and putting the new cord in through the papillary muscle head. People's concern is that you may cause ischemia to the end artery of the papillary muscle head. How would you avoid that or reduce the risk of that happening?
Yes, I think that's a very good practical point. There are some Punjabi laws to follow, but I'll wait first for...
We're hoping to hear them.
You mean ischemia in the muscle itself?
Yes.
You switch to the fibrous portion. I don't think... Yeah, the last 3 or 4 millimeters is where the chorda tendina turn into muscle, that's fibrous portion. So I used my bites there, just like chordal replacement. Mm-hmm. Every time you introduce something new, you open the door to new set of complications. So we first published this in the 80s, late 80s. And one of my partners replaced a mitral valve with a Bjork-Schade monostrut. And we suspend both muscles with Gore-Tex. I didn't see how he did the operation. A week later, the heart became pathologic specimen, but the muscle ruptured, managed to get inside the mitral valve and close the mitral valve shut. They wouldn't open and close anymore, the patient died suddenly. So the autopsy said, well, that's a bad technique. It's killing people. It's not bad technique, bad technician. As it turned out, the other one that was alive yet, the papillary muscle attached to the annulus. Oh, that's not how God made that stuff. God made it to papillary muscle to be at least a centimeter and a half away from the annulus. But you're right, it is a problem. If you pull too much, you can cause ischemia.
What's the Punjabi
it's just extending the same thing, really. Sometimes I tend to sort of look for the broken end of the chorda at the papillary muscle and tend to lift it up. And when you lift it up, you get the sort of tenting height that you do. So just go below that. And if you don't find anything, then you just use one of the thick chordae there and just lift it up. So
and put the annulus.
Just pull the annulus and then add it there. So it's
some surgeons leave pieces of native valve to prevent rupture. It apparently works as well. If you can preserve the whole posterior leaflet, even better. Take the anterior, but in rheumatics, the hole is usually very small. If you save the whole posterior leaflet, there's no place to put a prosthetic valve in.
In rheumatics, you really have to shave it off because you tend to...
In mitral stenosis, insufficiency, maybe you can do that.
Yes, I've got another important topic which I'm going to start, but I want to finish this now.
Thank you for your talk. In cases of severe rheumatic stenotic calcified mitral annulus, which is really small, and is there a red line when you can say, I cannot decalcify this and I cannot put a valve there? And if that's the case, what would you do? Would you...
You can always decalcify. The only thing is, you make for a complicated operation. You saw some video. The second video in the show, I replaced the valve. So I took the calcium out. There's a larger raw area. Put a strip of bovine pericardium in that case, and put a new valve in, secured in the bovine pericardium. We first described this operation in 1985, so it's a 29-year-old operation. The last paper we published is 400 cases, so it's not an experimental operation. Now, is that simple to do? No, it takes 2 or 3 hours to do this operation. It's not, but the key is to remove all the calcium and have a healthy muscle to sew a patch to it.
So you wouldn't consider arterializing a new annulus and putting the mitral valve, for example, putting a patch high up above the level of the normal annulus?
Oh, we can do that, yeah, sure. We do that in patients who require both aortic and mitral valve replacement, for instance, for endocarditis.
Yeah. We've done that.
There is nothing else to hold there. So you take a cylinder of that, clean the whole thing, then change your gloves, change the table, new instruments, and sew a tube of dacron graft between the ventricle and the atrium. A straight tube. Put a St. Jude valve inside. And then another tube between the tube and the aorta. So you have 2 tubes, one comes to the heart, one leaving the heart. We have 2 or 3 dozen patients like this. They all go home? No, 1 in 10 dies in hospital, but they are dying before operation. They all have an incurable disease before. So you don't do this. I have a beautiful video for this operation, actually, if you want to see it, but it takes too long to show everything. So, I mean, risk versus benefit, all depends what kind of situation you are in.
Yeah, I think
we don't want to do it in the first day of our practice an operation like this. You have to have a few routine mitral valve before you start putting patches everywhere in the heart. And,
My second question, Professor, in cases of reoperations, the era of quadrangular resections for the posterior leaflet has left lots of restricted posterior leaflets and recurrence of MR. Would you consider patching the posterior leaflet and putting neocords for these patients rather than replacing the whole valve?
No, you can patch posterior leaflet very well. The free margin is a problem. If you can preserve the free margin and patch the belly, is no problem. Every time I put a patch and the informatics to extend the free margin and from the patch create chorda tendina, those come back in 7, 8 years. When I was in England in 78 with Sir Magd, he was patching everything. He was taking autologous pericardial, dipping in glutaraldehyde and putting patching aorta, mitral. So I went home, I started patching everybody as well. 7 years later, they all started coming back. So I called Sir Mag and said, Mag, what is this? No, we stopped doing that kind of operation. They're no good anymore.
Well, we didn't tell you we stopped.
I never published them things. You have to publish, that's bad. So I published it. When you patch, the durability shortens like...
I mean, again, you can use your knowledge of anatomy. The calcium is sort of horseshoe-shaped or generally posterior, and so when you decalcify, I haven't done the tube operation, but the other one is where you create the sort of aortomitral outside with the flap and then in severe infective and then stitch, and then you have a sort of neo-fibrotic left and right fibrous zone, and then you can stitch it and hold it there. So that's possible, certainly. I do want to move to the topic of ischemic MR, if we've got no more questions here. A bit dear to me. We published the RHYME trial results, which was in moderate MR. Now, of course, we don't know much about the long-term survival, as you've presented some, and Mike Ecker has presented in the very recently. But we should really try and look for much earlier. So there comes the question of, should we look at moderate MR and start intervening on them? Should we sort of not allow the ventricle to dilate and start intervening on them? Should we go to the point of reassessing the definition of moderate MR? Because unlike TR, we don't really have a very good clear-cut definition of moderate MR. And a lot of patients during the RHYME trial recruitment who were labeled moderate when they went for their assessment by stress echo turned out to be severe MR. And then so we had to go back to look for mild MR. What's your feeling for that?
I think we talk a lot about ischemic MR, But how many do we see a year?
Quite right. Not very many. And this era of primary
I do
PCI,
about
less and
100
less.
mitral valve repair for myxomas every year, consistently, 90 to 110, depending how much I travel. And I do no more than 5 or 6 ischemic a year. And I repair them. I don't care, but I always repair. My partners replace.
But is it because
Do I have no recurrence? Of course I have recurrence. But I still think repair is better than replacement because there's no prosthetic device in the patient. I do sever the secondary cord attention, though. I
read your paper on that.
I started back in 2002, never stopped anymore. I think it made a difference. On the medial half mitral valve, we severed the strut cord, the anterior leaflet, and all the secondary from the posterior, and put a smaller ring. That seems to reduce the risk of recurrent MR. But it's not a perfect operation. I think replacement is a sure thing.
But do you think also that there is this possibility that we are not catching these patients early enough? Although I agree, we are not seeing so many severity.
Well, then it means that we stress test every patient before coronary bypass with the occlude the right coronary artery.
Yeah.
And see how many develop MR during exercise.
Or maybe re-educate the cardiologist a little bit, I guess, from not so much from our side. I think the one important point that you mentioned was that if the ejection fraction was less than 40%, you would replace. And more than 50% still attempt repair. And there's nothing like you follow a strict guideline for a set number of size of the annuloplasty ring. Although in Rhine,
I don't use less than 26. If it's less than 26, I don't care the size of the patient. The patient can have functional stenosis.
Yeah.
I think the benefit of mitral valve repair is abolished between 24 and 26 for a rigid ring.
Yeah.
For a bend, perhaps you might get away, but I don't think bend are good for cardiomyopathy or for ischemic MR.
Yes, I was just coming to that. So Steve Bowling's idea of doing this, but didn't work in the non-ischemic cardiomyopathy, but still works in the sort of ischemic MR. We were just looking at some of the predictors of recurrence of MR, not necessarily for ischemic, but also for, yes?
Well, let me jump in on one. I'll bet you one of them that nobody likes to talk about because it's our fault is annular dehiscence.
Yes, absolutely.
You put a rigid structure in a large bag of a heart.
I'm sure you've done some reoperations for that.
Oh, many for those. That's why I know it happens. And I use a bunch of suture. My annuloplasty has the complete ring about 20 stitches, and it's still because there is no annulus.
Yeah, absolutely.
On P2, most human beings don't have an annulus. So you're securing the leaflet, you're securing whatever you think is the annulus. The little dimple where the leaflet attaches to the ventricle. Oh, it's not strong enough. Those perhaps you should put a pledget.
Well, yes.
Lift the leaflet, put the pledget in the ventricle.
And also less compression. But of course, if the pathology is there, then you have to. But yes, I think the idea is compression where the pathology is, compression where you don't need to necessarily do it. So avoid that. It doesn't have to be a generalized compression all over the annulus. That is again bad as well. Yeah. Any other questions, discussions, points before we? I am going to go through my.
Well.
Oh yes, of course.
Two questions. What's your position with regards to tricuspid annuloplasty and people having mitral repairs? There's a tendency now to try and do more tricuspid valve annuloplasties.
Yeah, if the patient has moderate or severe TR, I do something about it when I repair the mitral valve. If it's only dilated annulus, I don't touch. Remember, half my patients have Barlow's because if you train a large group of surgeons in our town to repair mitral valve, they are my number one referral. They filter the P2s, they send me the Barlow's, and they calcify the mitral annulus. So I do a calcify the mitral annulus or advanced Barlow's at least once a week. So as a consequence, I cannot afford to do what you could have done with a P2 prolapse. It's a more complex repair. So you won't be able to do the same thing you do with simple repair. So
You should never say never in medicine, but do you, most of your approaches to the mitral valve go through the left atrium, or do you sometimes say, no, I'm going to go through the right atrium?
it depends.
Isolated mitral.
If I'm doing combined to the aortic valve, I don't go to the left, to the side atrium. I go to the domed left atrium. The exposure is magnificent to the dome. You make a transverse incision in the dome, 1 centimeter away from the insertion, put 2 or 3 stage sutures, the mitral valve is in your nose there. It's very simple. If it is, however, isolated mitral valve repair, I always go to the intra-atrial groove. Particularly if it's simple repair, which I don't do very many, then I do thoracoscopically. I don't do Barlow's thoracoscopically. It takes me too long. I can do it, but it's 3 hours in a pump. I can do it in 1 hour with the sternum. So I simply tell the patient, your valve is repairable, but I want a small incision, mini sternotomy, but through the sternum.
Yeah, I think there has been a lot of debate. Certainly, I think Rakesh Suri has presented quite a good about moderate TR in patients undergoing left-sided surgery. But there's growing acceptance that more and more intervention is probably needed. I think for the worst thing that we are seeing patients coming back.
Well, after mitral valve replacement, after repair, no. We in this cohort of patients, my first 840 patients I operate on, in those days, I only repaired the thoracic valve for severe TR. During 25 years follow-up, only 11 patients developed TR. I mean, 11 patients, 840.
Yeah.
I mean, that's gosh, that's less than 1%.
Yeah, it's a small number.
You got to put in 40 material in the thoracic valve. On a Dreyfus database set, was 40% developed TR. I don't know what he was doing in France, but that seems high.
Yeah.
And the paper that he quotes, if you take a look at the paper published in Annals, 40% of his patients who had mitral valve repair developed severe TR within 5 years. That's a lot of TR.
And people
I don't see this.
People use the sort of 40 millimeters on echo as the...
For the AP diameter.
Yeah, as the sort of...
But in
cutoff.
Barlow's, since I was telling him most of my cases are Barlow's, if you take a look at a Barlow's mitral valve, frequently the thoracic valve is Barlow's too. So the end is going to be more than 40 millimeter. So should they repair all those?
Yeah.
I mean...
Well, I think there were divergent views, 2 papers which were published very recently, just having complete divergent views. So I think the question is still out in the open. And
I'm sorry, the rheumatic patient is a problem. Even if they have a normal thoracic valve, entirely normal, when you replace the mitral valve in those rheumatics, between 20 and 30 years later, close to 100% come back with TR, and I don't know why. If it's deformed, and so late thoracic valve repair in rheumatic and mitral valve replacement is a common operation.
yes,
And not very good, by the way. Not very good because
Yes,
cardiologists
exactly.
sit on them with Lasix, until they can, they're in anasarca, then they send it to you. You take a look at the right ventricle, it doesn't move anymore. Well, they die if you
and the right atrium is almost like wet tissue paper.
That's
when you
right.
do the reduced sternotomy, it's murder.
So those are a problem, and I perhaps in rheumatic you should put a ring in every thoracic valve, not
Perhaps.
only 40 millimeter or higher.
Yeah.
And I just wonder if many patients that Dr. Dreyfus operated on in France were not rheumatics. I mean, just mitral valve repair, but were rheumatics, and they might behave the same way.
Yeah, yeah. And a lot of people are trying to sort of enforce a 5 to 6 millimeter of coaptation depth in the... Now, again, we are trying to, the same chap who's going to do some work on the mitral with body surface area is trying to look for this area. Does it sort of pan out throughout, or is just...
No, only P2. There's no way you can have a 5 millimeter in the commissures.
And what is...
The commissures are not 5 millimeter tall. How can you have a 5 millimeter coaptation when the leaflet itself is only 5 millimeter? It's a physical impossibility. So the 5 millimeter is along P2, A2, and then become 4, 3, like in the commissures,
As
1, 2 millimeter the most.
And the role of secondary commissures that you find sometimes between P2, P1, P2.
Some of them come all the way to the annulus. I think they should be closed.
They should be closed.
You're going to put a band anyhow, so it's going to stop moving.
Yeah,
So may as well
yeah.
close it.
I think that's again a case of, as you said, we are very confident nowadays of getting patients out of the table with a competent valve, but is it durable? Is it long term? So that's probably what is determined by adequate cooptation and closure of.
But that's why I start by saying you have to describe our operation to yourself, to your records, in detail.
Yeah.
So when they come back to the failure, you read again and say,
This is what it was.
that's where I did wrong. And because nobody else is going to teach you anymore. After your
No,
your
you're quite
mentor's
right. I
gone.
think the important point, as you said, that you tend to become your own mentor.
Mm-hmm.
We've just submitted an abstract with one of the chaps here of sort of 1,700 Asian ethnic minority patients that I somehow end up operating, and their follow-up and mortality data, and just to look at what are we doing right, are we doing something wrong. And so I think that's again quite important, a sort of reflective practice to look at your own, and we have a follow-up of 12 years now. So.
I don't know how many of you follow the Society for Thoracic Surgeons database in the United States. It started back in 1988. Now it's up to 4 million patients in the database. We just joined this year. When I was very active in American political medicine in the United States, with the AHS, present AHS,
Yes.
I was involved in all this. There were approximately 180 enters per patient. Do you know how many the new one has now? Over 500.
Oh gosh.
I mean, it takes longer to fill up the damn thing than to do the operation. I mean, because they are discovering that everything is important, not only hemoglobin level, not only creatinine level, but what we do in the operate room, what kind of suture you use, how many knots you throw. I mean, gosh, I never count how many knots I throw. I tie and
But do they expect compliance with it? Do they expect compliance with this? I mean, that's sort of, a database is as good as the data.
But that's the problem. Compliance can be low. And,
exactly.
So, and all this is pertinent to when you analyze the outcomes.
Oh yes, absolutely, absolutely. I mean, you cannot have any meaning if the data you put in was not complete or adequate. Yeah. Do we have any more questions, doubts, anything else we want to? I think
one last question to both of you. I was fortunate enough to be trained for mitral valve repairs by yourself, Mr. Punjabi, and I will remember all the Punjabi tips and tricks. It's just a matter of getting referrals in your first couple of years as a mitral valve. You don't get many of the P2s. You do get some of the mitral valve endocarditis. But I was just going to ask both of you, as a young resident, as most of these are, or a young consultant, how would you develop a mitral valve program and take your learning curve up?
Well, I don't know. I practice in a different era. I practiced where I had a 6 months to a year waiting list. And as a chief, I said, I want to learn mitral valve and aortic valve. So I gave my partners the rest, and I cherry-picked all the mitral valves to repair. So any patient was in the queue of my unit with mitral insufficiency, I said, that's mine, and you guys can take the... So I was very fortunate, very lucky to work in a place that used to do 3,000 operations a year, and every year there are 4,000 patients in the queue. So 1,000 roll over next year. Those days are gone. My younger guys now struggle to get to fill their OR time even because there are too many units. The government, in their wisdom, decide to decentralize patient care for political reasons, to be reelected after they study from Harvard. I don't know if you ever read it, when they assign value to physicians.
Yeah.
Where some 2,000 citizens in Boston area were quizzed by a reputable agency. What is important in healthcare? Boston has 5 medical schools. 5, not 1. Toronto has 1. Guess what's the most important thing for the patient to choose a hospital to go to? Guess. Published in the New England Journal of Medicine. Okay. Free parking lot. Free parking lot. Second, good food. Reputation of the surgeon, in the bottom of the list there. Well, the moment the politicians alerted nobody cares how good you are, they said, give the people what they want. hospitals everywhere, free parking lot, and with that, we are paying the price now. Expertise are diluting, and so I'm sort of, I don't know how you guys are going to do. You have to have a very kind cardiologist who's willing to develop a program and partners who are willing to make you the mitral valve surgeon. Otherwise, it's impossible.
And I guess, no, it's very similar. I mean, I was fortunate enough to be appointed in N98, and in March 99, I got Jacques Seguin with the Seguin ring to come over and proctor some cases with me. And then I went to a lot of DGHs and did a lot of talk and tried to tell them that, look, I can do this, I can do this. I was also fortunate to work in a group who was not much interested in mitral. Oh, what is this mitral? You know, it was all about aortic at that time. It was a lot about aortic.
No, mine was about coronary bypass. It pays a lot in Canada.
Yes.
It pays twice more than a mitral valve repair.
It was a lot in coronaries as well.
So you want to have points to keep up our salary up.
And I guess now it's really having a buddy surgeon or somebody who's been through this and is, you know, reaching a point where he's not threatened, probably the best word, and then is willing to. I mean, you have to, because maybe, you know, the skills in the new people are bound to be. They can do a lot faster play games than I can. So yeah. I'm sure that's probably what
I believe in repetition makes perfect. That's why I think it's a disservice to society to dilute healthcare in too many places. The patients do not know what's best for them. We do. They don't. They want a free parking lot. I mean, can you imagine I'm die from a heart attack when I go to a place where I can park my car? I mean, keep me alive first, and then I'll worry about my car.
Well, that's quite right. That's a very, this was an editorial followed with this article as well. It was a very important article published in the New England. And of course, it's you know, the patient's perception. But you're quite right. Ironically, patients seem and come up and say, oh, I'm well educated, I've seen you on Facebook or whatever, but actually he's not. It's completely a different level that he has looked at. He has no clue about what the actual operation involves. That's my...
Isn't internet affecting your practice here? They do research before they come to see you?
Yes.
But are we actually seeing a drop in the referrals because of that? I don't know, because that's something you'll never come to know, you know. You get to see a lot of patients. My son looked you up on Facebook. Oh, there's a video of yours on whatever, you know, we've seen it. But what about those who saw this and say, oh, I don't want to go to him? We never know. I mean, I don't know.
No, but more than that, if their cardiologist sent to you for mitral valve repair, they bring 20 articles, all to the internet, none of them peer-reviewed, and put in your tables, you're supposed to read out 20 garbage and say, you know, where did you get this? Oh, Ed, if I put minimally invasive mitral valve, everybody's saying, robotic take care of it. I don't need a human being to do my operation anymore. So wow. So I mean, I'm on a robot to do my valve repair. That's the level of intelligence.
Yeah. And I think one of the important things that I've also learned now is the fact that, you know, you will have to pay the price for your own mistakes. It's very... If you're lucky that you can discard your mistakes somewhere, it's fine. But in my practice, these all seem to come back to me.
To haunt you.
So you really need to hone and every time learn and do better so that every mistake that comes back teaches you a lesson to see, okay, this is... And again, going back to the point of, did you record what you did properly at that time in the first instance? I think it's been very interactive, very interesting. It's a privilege to have Professor David on the table.
Thank you.
And it's really been an honor to have a tete-a-tete with him. It's really been great for me as a learning experience, and I'm sure it's been great for you. We really are very greatly indebted to Professor David to have taken the time and the energy and go through this from basics. Really very interesting, very thought-provoking, and I'm very grateful and thank you.
Thank you.
Thank you.